Good afternoon, everyone. I am Dr. Naga from Navya, and I welcome all of you to this webinar on multidisciplinary management of malignancy of unknown primary and head and neck cancer. So we have come across several cases, and this is in association with Assam Cancer Care Foundation. We are conducting this webinar with the help of the panel members. Our esteemed panel members are Dr. J.P. Agarwal, Dr. Vijay Patil, and Dr. Shivakumar Tyagarajan. So I welcome all the panel members to this webinar. So Dr. Jaiprakash Agarwal is Professor and Head of Radiation Oncology, Tata Memorial Hospital, Mumbai. And we have Dr. Vijay Patil, who will be joining us shortly. He is busy with some emergency workup. So he will be joining within another 10-15 minutes. He is the Professor and Head of Oncology for PD Hinduja Hospital and Medical Research Center, Mumbai. He is ex-TMH. And I welcome Dr. Shivakumar Tyagarajan, who is the Professor of Surgical Oncology, TMH, Mumbai. So I welcome all of you, sir, to this webinar. And I welcome all the participants to this webinar. And I hope there will be a good interaction among all of you and a good learning experience. So about Navya, Navya is a cancer informatics and patient services company that leverages technology to provide personalized evidence-based cancer treatment plans with the help of experts like we have in the expert panel here. And we also work with the state governments wherein we are working towards the standardization of cancer care and we work with the government institutions in this effect. So one of the such association is with the Assam Cancer Care Foundation, wherein we are working with the Assam Cancer Care Foundation for standardization of cancer care in Assam. So with this small introduction, I would like to speak about our panel members. I welcome Dr. Jaiprakash Agarwal, JP Agarwal sir. We are happy to have you on the board today. Dr. Agarwal has 20 plus years of experience in radiation oncology with a special interest in head and neck and thoracic malignancies. He has mentored several PG students and PhD students and is a member of board of studies for several universities. He has several awards and accolades to his credit and has authored more than 300 publications. And he is a regional editor of Clinical Oncology, which is the official journal of Royal College of Radiologists, and an honorary member of European Society of Radiotherapy and Oncology. I welcome you, sir, to this webinar.
Thank you.
Dr. Vijay Patil, he will be joining shortly. He is having 16 plus years of experience in oncology. He is qualified both in medical and radiation oncology. He is ex-professor of TMH Mumbai. He established the solid tumor medical oncology department at Malabar Cancer Center, Kerala. Again, he has a special interest in head and neck cancer, CNS tumors. He has published research papers on low-dose immunotherapy, which helped in reducing the cost, and also oral metronomic chemotherapy with increasing efficacy without increasing the cost. And then received esteemed Adley Research Award in recognition for his exceptional contribution in oncology. He has authored 500 publications, and he will be joining us shortly once his emergency work is completed. I welcome Dr. Shivakumar Tyagarajan, Professor of Surgical Oncology, TMH Mumbai. He has 20 plus years of experience in head and neck surgical oncology. He is trained in head and neck surgical oncology from Kidwai Institute of Oncology, Bangalore, and TMH Mumbai. He has special interest in management of oral, thyroid, and skull-based malignancies. He is a surgical expert in head and neck surgery and oncology, skull-based surgery, and general otolaryngology. He has an additional expertise in microvascular reconstructive surgery and translational research. He has published several book chapters and research articles in various peer-reviewed journals. I welcome you, sir, for this webinar.
Thank you.
So with this short introduction, we would like to go with the case presentation. I welcome Ms. Bhavana Sri to present the case that we have shortlisted for the webinar. Ms. Bhavana.
Good afternoon, everybody. So I'll be presenting a first case of squamous cell carcinoma of unknown primary versus locally advanced oropharyngeal cancer. So, patient is a 41-year-old female with a family history of oral cancer, no history of smoking or no history of alcohol consumption, presented with complaint of right-sided neck swelling and pain in August 2023. Prior to this, she also had a right neck cyst, and a cytology showed no evidence of malignancy in May 2023. So MRI of the neck in August 2023 showed bilateral large parotid gland lesion, multiple left level 1B, bilateral level 1, bilateral level 2, level 3 lymph nodes, largest measuring 2.3 into 2 centimeters, left level 1B lymph nodes, internal necrosis and eccentric soft tissue components, bilateral large palatine tonsils were noted. Patient's HIV and hepatitis panels were negative. An excisional biopsy of the left mandibular lymph node showed squamous cell carcinoma. Pathology note, metastatic squamous cell carcinoma. FDG PET-CT in September showed left mandibular and left upper cervical cutaneous, subcutaneous plane postoperative lesion with an SUV of 4.6. 1.4 into 1.4 centimeter left cervical level 2, level 3 lymph nodes were noted. Bilateral breast nodule calcifications noted. The calcification measuring 1.5 into 1.5 centimeter, SUV 1.7. Bilateral palatine tonsil uptake was noted. There was no evidence of malignancy elsewhere. Radiology notes said left-sided upper cervical lymph nodes, likely metastatic, mildly FDG avid right level 2 cervical nodes, likely benign, nodularity in the breast parenchyma, query benign. In a view of non-visualized submandibular gland and primary mitotic pathology of the metastatic cervical lymph node, may be submandibular salivary gland. Mammogram of the left and right breast showed no evidence of malignancy, September 14, 2023. A direct laryngoscopy of the left tonsil lesion showed left tonsil lesion. A slide block review of the left submandibular lymph node showed squamous cell carcinoma, metastatic squamous cell carcinoma, grade 2, with no perinodal extensions. Clinical staging, stage 3, T0 to T1, N1, M0. On October 30th, 2023, TMC NCG Navya online expert opinion recommended diagnostic test with P16 testing and biopsy from tonsil. Further, based on the above mentioned diagnostic tests or findings, definitive concurrent chemoradiation therapy may be considered. Core biopsy of the left tonsil on September 15 showed dysplastic lining squamous epithelial, no invasions, no evidence of malignancy. Left submandibular lymph node slide block review showed squamous cell carcinoma with IHC negative for EB, ER, IH, ISH, EBV, LMP1, P16. So CBC was within normal limits. RFT and LFT details not available. Ejection fraction of cardiac ejection fraction 60%. Functional ECOG score is 0. General condition, patient able to do all the activities without any assistance. No significant disease-related symptoms noted. Patient has resource constraint. Treating oncologist has planned for concurrent chemoradiation therapy. Patient preferences, patient wants to avoid chemoradiation therapy or radiation therapy, however, is agreeable to surgery or active surveillance. Navya questions, given P16 is negative and no evidence of malignancy in left tonsil, consider lymph node dissection versus concurrent chemoradiation therapy with cisplatin versus definitive radiation therapy versus alternate. If radiation therapy is recommended, then the preferred dosage and fraction.
A little request for Navya.
Yes, sir.
So most of the time they provide the reports, but basically when we are choosing this type of webinars, it is preferable to have image also. That is a humble request. Okay.
Okay, sir. Sure,
So
sir.
that will give much more information and dissemination of knowledge. The second thing, as a learning from this aspect, what do I understand? So whenever a patient of a neck swelling comes, I should not do a straightaway excision biopsy. So that is one learning. So we should be doing FNAC to begin with, or some sort of a biopsy rather than an excisional biopsy. The second learning is imaging should be done at FNAC, not immediately after an excisional biopsy. You can see a post-op edema, etc. What we saw, somebody read to me in the PET scan report. The third learning is, especially whenever we are talking about head neck, appreciation of a dental status will help, especially when you are planning for some sort of radiation therapy. Lastly, I think that the Navya experts have definitely asked for some good things, like they want to see a P16 and an EBV virus to help where is the node. So likelihood that a careful examination of an oral cavity, which was not written here. So everything in the report, it is given, like you have given me this and that, but somebody's examination of an oral cavity in a mandibular gland is of utmost importance. So imaging will not tell me anything about a mucosal or a submucosal lesion very well. So whenever we are dealing with an unknown primary, a good examination finding, a dental finding, a alveolar status is recommended to be understood and to be documented here in a Navya to have a very clear-cut recommendation from the experts. So that's one of the things which I wanted to say.
Yes.
Secondly, definitely in case this is to improve of self-learning, there is nothing called query T0, query T1. Okay. So if I have to go and learn about TNM, one of the basic principle is we have to understage it. So definitely on examination, on investigations, we have not seen an oral cavity. So it is a T0 N2 because it was 2.3 centimeter or something like that. If I recollect well, I don't recollect. So it was something like
2.3 into 2 centimeter.
So it should be a N2 rather than N1. Okay. No, I think it is 3 centimeter. No, it's perfect. N1 is perfect. So the treatment is, if you have done a good local treatment of complete excision in form of dissection, no extranodal extension, I think we have to see the pathology size and the perinodal extensions very, very well. But historically, in cases of N1 disease or N2 or extranodal extension, the classical teaching is chemoradiation, followed by a PET and followed by a excision or a dissection. But some people, if there is early disease, some people have done a dissection when they really don't want to do any irradiation. Okay, so but these things are to be discussed much before. Then a plan has to be executed, and definitely this patient doesn't want radiation, so you can't force upon them, right? So
Yes,
go
sir.
back and see the histopathology much in detail. And if the patient is absolutely keen of they don't want irradiation of any form, wait and watch. But the outcomes have been a bit low in comparison to when only dissection was given or when only neck was irradiated in comparison to A classical unknown primary irradiation includes a mucosal irradiation as well as neck irradiation. So patients who have received a mucosal irradiation and the neck irradiation, they had the best locoregional control and survival. And that's all from my side.
Thank you, sir. And we will definitely, we have taken note of your suggestions on the improvements. We will definitely work on that. Thank you for your comments, sir. And Dr. Shiv Kumar, sir, please, can you please provide your views on the case?
Right. So I kind of agree with most of the points what sir said. And yeah, I think the foremost thing here is, I think I'll divide what I'm going to say based on the workup and the subsequent management. So I'll just initially start with the workup, because I feel the workup, I know the
Yes,
details,
sir.
at least complete workup details are not provided. So which is essential, because a lot of the residents and fellows have logged in, which they need to know. What was said, I think if there is first of all, we need to do a proper examination of the oral cavity apart from the head and neck, and document if there's anything, suspicious, any mucosal lesion which is there in the oral cavity, oropharynx. That can be done with a clinical examination, and of course, fiber optic laryngoscopy and a nasal endoscopy, just to see if any of these upper air digestive tract has any suspicious lesion. And one should not go ahead with a biopsy upfront unless and until it's obviously, suspicious. So a clinical evaluation of all these aerodigestive tract is very essential. And, once that is done, when you're investigating the patient, we have to do an FNAC or a true cut biopsy, not an open biopsy as what sir suggested, because we shouldn't jump in to do an open biopsy, and because especially when you're suspecting squamous cell carcinoma. And whenever we are doing an FNAC or a true cut biopsy, especially in a 1B site, it may be better to do an image guided true cut biopsy, for the reason that, especially in an area like 1B, when you do a blind biopsy, what might happen is you take some amount of submandibular salivary gland tissue and go into the node, and that will come in your specimen. And sometimes that can be mislabeled. You're seeing some atypical cells and some salivary tissue. It may be labeled as a salivary gland malignancy rather than a metastatic node. So if you target it with an image guidance into the nodal tissue in an area where you can get a representative sample, that will be best. And especially when you're in level 2, you want to be careful. You want to stay away from the vessels. So an image guided true cut biopsy would be best whenever possible. And if somebody, as a last resort, wants to embark an open biopsy, they should go in with an idea that if needed, you're going to do a completion neck dissection. I mean, that's a last resort. You don't want to do that. But if you're going to open up the neck, you should be in a position, you should take a consent that you might have to do a formal neck dissection. And you should be sure that you'll be able to do that. You don't want to go into a neck which is unresectable. So if that is the case, a true cut biopsy should be, sufficient. And as much as possible, avoid, as what sir said, an open biopsy, right? So once you're done with the biopsy, you have a squamous cell carcinoma, the node is 1B. Now, what are the likely sites from where the 1B, what are the drainage basins for 1B? That is oral cavity most commonly, followed by the oropharynx. Oropharynx for 1B is definitely possible, but is lesser compared to oral cavity. So your index of suspicion for a possible oral cavity primary, which is hidden somewhere in the vestibule or in the retromolar trigone or some hidden site in the floor of the mouth, you should be thinking about that and do a proper examination to rule out any oral cavity primary that is there. And of course, you need to examine the oropharynx, the nasopharynx. And before you do any biopsy, you must be doing an image. As per the ASCO 2020, recommendations, a CECT head and neck is good enough to begin with and would be probably available in most of the institutes. You don't have to you don't have to do a PET scan all the time, but if you have it, patient is able to afford it, please, PET scan is probably better, because we have evidence to say PET scan has better sensitivity, specificity to pick up a primary compared to a CECT. But then having said that, a CECT might be just good enough actually. So once you're done an imaging, you have something suspicious, you have to do an image guided biopsy. So any suspicious area on imaging, you have to look for that in your upper, aerodigestive tract endoscopy and do a directed biopsy rather than doing random biopsies, which is condemned, which is not to be done, right? So you have to do an image-guided biopsy. And once you have done all this workup, you still don't have a possible primary. That's when you truly label it as a metastasis of unknown origin, and that's when you call it a T0, right? And as per the recommendations, we need to do a P16 and an Eberish to rule out any possible hidden primary in the tonsil or the nasopharynx, which has been done, which is negative. It's great. So the next question is there a role for tonsillectomy and mucosectomy? That's, talked about, debated across many, in many conferences and workshops. But in India, we don't do it often. Now, that has been done. There's a lot of literature coming from Europe, from the North American countries, and some parts of Australia. But then in India, if you ask me, is there any literature on mucosectomy and tonsillectomy? There's not much, very, very limited. And in our practice, we don't follow that often. What we do is we do a true cut biopsy and do a P16 on them, and to look at whether it's P16 positive or Eberish, is positive or not, because that will probably give a hint as to whether the primary is harboring is there somewhere in the oropharynx or in the nasopharynx. And as Sir said, the mucosal irradiation can be restricted. Like as per the ASCO recommendation, if it is P16 positive and Eberish negative, the mucosal irradiation can stop at the level of the hard palate. You don't have to irradiate the nasopharynx, because you irradiate more mucosa, as Sir can correct me if I'm wrong, the toxicity would be much more, right? And the patient's completion of treatment would be better. So, and also as per the recommendation, if P16 is negative is when you do Eberish. You don't do Eberish when P16 is positive. That means the primary site is mostly in the oropharynx and you don't have to do an Eberish. But if P16 is negative, then you have to do Eberish to rule out if the possible primary in the nasopharynx. But having said that, from India, the incidence of HPV positive oropharyngeal malignancy is less than 20%. The latest systematic review from India and taking into literature from across the world, and especially in India, it is less than 20%. And once you've done all this evaluation, then it's a truly metastasis of unknown origin. What is the best treatment? We don't have any randomized evidence to compare head-on upfront neck dissection followed by adjuvant versus chemoradiotherapy followed by salvage neck dissection, which is better in terms of overall survival and quality of life. Most of the data that we have is on retrospective, series and systematic review of those retrospective series and a few prospective studies. We are presently doing a randomized control trial in this, but these are early days, but we are attempting to do that. So in literature, you have both the treatment options available, and what you follow in institute may vary based on your institutional practices, but you have evidence for both. Of course, you wouldn't want to do a neck dissection when the node is unresectable. And also the patient preferences are also to be taken. Like in this case, the patient is worried about the non-surgical treatment aspects. But of course, proper counseling is essential before we have to offer them what is probably the best treatment option. The other thing that needs to be considered here is it's a 1B node, right? And we have had this discussions in our tumor boards as well. When it is 1B, irradiating the neck with a 1B, the radiation oncologists and the surgeons, the clinicians are worried about the mandible there, because it will come in the field of radiation. The chances of OR and many other aspects are there. So some institutes, they may prefer to do a neck dissection and followed by adjuvant radiotherapy for that reason. May not be in, some may disagree with me, but we have done this on many instances. But then we need to weigh the, the advantages, disadvantages. What is the level of the node that is there? If it's a level 4 squamous cell carcinoma, I would be a bit, worried about doing a neck dissection upfront, even if it is resectable, because that tells me that it's an aggressive disease and it's probably even there's some disease lurking somewhere else, and I might not be, very successful by just doing a neck dissection. So various other things needs to be taken into consideration. And as far as mucosal irradiation is concerned, I think Sir is the expert to talk about that. But with my limited knowledge on that, it adds to the toxicity. And of course, even that is a debatable, concept, even in the field of radiotherapy, with the proponents and opponents to it. And of course, there's no head-on comparison in terms of randomized control trial as to whether mucosal irradiation adds to the survival benefit, whether that toxicity that is associated with mucosal irradiation is worth that. We don't have that data yet. So that is again a debatable issue that needs to be discussed with the patient. So as far as this patient is concerned, the neck dissection is not complete yet. They've just done 1B, nodal clearance. So, and if the patient is concerned about receiving a radiotherapy, I would probably suggest a completion neck dissection. And I don't see the images. I need to see whether I'm okay with just doing an ipsilateral neck dissection or should I do bilateral neck dissection. That is the other question that we need to discuss with the patient. And then if there are bilateral nodes that are positive, then the patient would require adjuvant radiotherapy anyways. And there's no question of observation or active surveillance in this patient because the patient has not completed the entire treatment that needs to be given to the patient, right? So those are my observations and comments. Thank you.
Thank you, sir. Thank you for an elaborate input on so many things you have covered, starting from the workup till the treatment option. And now I request participants to ask their questions. Sir, you want to add something?
Okay. After the participants have asked their questions, I can we can discuss that and add to Dr. Shiva's thought processes too.
Yeah, participants can ask questions if they have anything, either in the chat box or you can ask now by unmuting your speaker. Sir, Sir, you can add your points, sir. I think there are no questions.
So Shiva, thank you for taking us along. I completely concur with you that we don't have a randomized studies, and unlikely they will come in future because let's see the perspectives. So most of the unknown primaries in a head neck will be level 2, level 3, and very uncommonly 1B or 1A or 4. If I have to say perspectives, around 5 to 10% will be unknown primary, which will be coming to our clinic. Among them, out of 5, mostly 4 will be possibly from the level 2 and 3. Right, Shiva?
Yes,
so
sir.
Generally, that's the norm.
Yeah.
And let's say they generally come with the largest node, maybe N2s most of the time. So they need a combined modality treatment, irrespective. So that's one perspective. And historically, TMH and other places, we have never done a blind biopsy. And the reasons are fair enough, because for the time being, let's assume for a classical, for anybody it was a learning process, that we will have a T1 N2 oropharynx. Okay. So how do we proceed in a known case that we will do a complete chemoradiation followed by imaging, and if required, a salvage neck? And let me extrapolate from there that there is an unknown primary or such a small primary which cannot be visualized or even seen by imaging studies. And that's the way generally I thought it, and I proceed. There is no doubt, and I emphasize what Shiva said. The more the mucosal irradiation, the more the toxicity. Toxicity in terms of xerostomia, swallowing, and so many other toxicity of head neck. There is no doubt on that. But possibly not to irradiate mucosa, which several groups have done it. And several groups have done also for only ipsilateral irradiation rather than a bilateral irradiation, which normally is a trend in India to treat both sides of the neck or most of the world. as less you will irradiate, especially in HPV positive, you will have lesser toxicity and nearly the better control, especially with the new staging systems. But essentially, our common practice is mucosal and a neck irradiation. So that is the common practice with a concurrent chemo, especially if they are on a largest or N2s and N3s, or when we see extranodal extensions. So that you can extrapolate from Mehana's paper, like when you have a largest node, you should always go with CTRT and followed by do a PET and if required, a neck dissection. That's the thought process I think we can extrapolate till we have head-on studies. And also, we will never have a level 1 or level 2 separately stratified unknown primaries, because it will take really, really long time to do that. But essentially, what is important, a good examination of oral cavity in a good light, and anything abnormal, you can do a specific imaging and a biopsies, especially at the floor of mouth or any of the gutters. That is the key for unknown primary. And I'll stop short of that. Thanks, Shiva. Thanks. You made my life very easy.
Thank you, sir.
Thank you, sir. Thank you for your added comments. Now, since there are no questions, we'll move on to the next case. I invite Ms. Bhavana Shri to present the case.
So our second case is early salivary gland cancer versus unknown primary. So it's a 60-year-old female with no family history of cancer, presented with complaint of right mandibular swelling, November 2023. An MRI of right submandibular showed 2.5 into 2.4 into 2.3 centimeter right submandibular gland, anterior inferior aspect lesion, abutment of the lower border of mandible in the superior lateral aspect, abutment of the right-sided belly of the digastric muscle in the superior medial aspects. A fine needle aspiration cytology of the submandibular salivary gland showed mucoepidermoid carcinoma. Patient underwent curative definitive upfront surgery on December 9th, right submandibular gland tumor excision with right supramyohyoid neck dissection. Pathological tumor size of the surgical sample showed 3 into 2.8 into 2.4 centimeters. Final surgical margins were negative. 0 out of 13 lymph node dissected showed negative for tumor deposits. Perinodal extension was noted. Malignant disease, squamous cell carcinoma with grade 3. Lymphovascular invasion was negative. Perineural invasion was not seen. Pathological TNM stage 2, T2, N0, M0 disease. Pathology note, the lesion on the inferior aspect of submandibular salivary gland probably represents a lymph node with extensive metastatic squamous cell carcinoma and extranodal extension. Please correlate with clinical and imaging findings. FDG PET-CT of the FDG PET-CT showed surgical bed hypodensity, SUV 3.3, abutment of surgical sutures in the right submandibular region, few right supraclavicular and level 5 lymph nodes, largest 1 into 0.8 centimeter, no evidence of malignancy elsewhere. Radiology note, post-right submandibular salivary gland tumor excision with right supramyohyoid neck dissection status, ill-defined focal hypodensity at the surgical bed, abutting the surgical sutures in the right submandibular region, showing faint peripheral FDG uptake, likely post-treatment changes, suggested short-term follow-up, a few tiny faint FDG right supraclavicular and level 5 lymph nodes, likely inflammatory, suggested follow-up, no other demonstrable metabolic active disease elsewhere in the whole body. CBC, RFT, LFT, cardiac function status not available, ECOG status not available, general condition not available, resource constraint status not available. Treating oncologist has suggested CT-RT. Patient preference, patient prefers proton therapy. Navya questions, given high-grade disease, consider adjuvant RT, 60 to 66 gray, 2 grays per fraction alone versus concurrent CT-RT versus proton therapy if affordable, available versus alternate. Are additional diagnostic NGS tests recommended for future treatment options?
Thank you, sir. Thank you, Bhavna. Now I welcome Dr. Shivakumar to provide his expertise. Sir, we'll start from Dr. Shivakumar and then come to you, sir.
Sure.
Sir.
No, go ahead, Shiv.
Yeah, yes, sir. So this is exactly what we discussed in the previous, case. As we said, the FNA going through the submandibular gland and into the metastatic node will be misinterpreted as a salivary gland malignancy, especially because the squamous cell carcinoma and the high-grade mucoepidermoid carcinoma under the microscope might be very, similar. It's difficult to differentiate. And if you see some normal salivary gland adjacent to this picture, it would be labeled as a salivary gland malignancy. So that's exactly what has happened, and they've done a supraomohyoid neck dissection. But you have labeled it as T2N0, so I don't understand how that has been labeled because we don't know the primary yet. That is one thing. And the other thing is that it is still a neck dissection 1, 2, and 3. It's a metastatic node, so it is a cervical metastasis with an unknown primary. And if you look at the other point is the number of nodes harvested is 13. Now, as per the recommendations, that is the ASCO recommendations, what is an adequate neck dissection? If you've done selective neck dissection, or you should have at least 18 dissected lymph nodes in your specimen. Now here you have only 13 neck lymph nodes. So this is not an adequate neck dissection to begin with. That is my concern with this neck dissection. And at the end of it, we still, the patient probably still has not received the complete treatment. And as per the PET scan, there's no disease elsewhere. But still, the treatment is not complete, in my opinion. And the P16 and Iberish still needs to be done in this case. And I'm not sure, I think it's not available, right? Please correct me if I'm wrong.
No,
it's
it
not
is
there.
not.
So I would recommend that to be done for this patient as well, because it's cervical metastasis of unknown origin. And lower down, if you can just go to your questions at the end of it, I think the rest of the aspects that we discussed are the same. Right? And as far as their question is concerned, they need to go ahead with the concurrent chemoradiotherapy. Whether it's with, of course, Sir will mention about the use of doing it with proton. And in my opinion, I'm not sure if NGS might add anything for future treatment as of now, especially in metastasis of unknown origin. So I think the patient will definitely have to undergo, concurrent chemoradiotherapy subsequently. So over to you.
Thanks, Shiva. I think you made it absolutely clear. But can I ask you a question, Shiva?
Yes, sir.
So that is the radiologist suggesting that that the small part of the inferior part of the submandibular area. Can we go back to that area in the slide section? So what the pathologist is suspecting that is the inferior part of the submandibular gland, right? They are seeing probably a lymph node. So is it a remote possibility? What I'm saying, a remote, I'm the guy is a devil thought, you know me. So can it be a submandibular squamous cell carcinoma? And is it a possibility?
So, of course, it is. One can never say never, but that's remote. Given the even rarer than metastasis or cervical metastasis of unknown origin. So, if we look at squamous cell carcinoma of the major salivary glands, parotid is common. Submandibular gland constitutes hardly 10 to 15%. Of the 10 to 15%, 60% is malignant.
Perfect.
Or 40%.
So basically, I wanted basically what I agree, completely agree, Shiva. So basically what I wanted our clinicians and the other colleagues to engage with the pathology and radiology. That was the point what I was trying to make it. So don't leave anything apart when you can discuss with your colleagues of their experts. Go back and again see. Definitely this is a nodal squamous CA. There is no doubt on my mind at least. But what I'm trying to say that always talk to your pathology, your radiologist, and we will be wiser as a treating clinicians, right? Because we will see some exciting things. And the another thing here is that extranodal extension, which is causing me some worries here, and especially with the suboptimal surgery. Unfortunately, that's what has been done already. So now the option is definitely we need to irradiate the neck and the mucosa. If the people agree on that, along with the concurrent chemo. I think Vijay is not here probably, and the chemo is possibly most of the time it is cisplatina. How you give a 3-weekly or a weekly, it's your system, and that's the common thing what we have been doing it. Now patients prefer proton therapy, and if I would have been a commercial entity, I would have never thought, why not? But let's see from a scientific perspective. So what I will do, I will draw my volume, which is the area to be treated. If I am treating the mucosa or the neck, irrespective ipsilateral or bilateral neck, I will do my best photon planning, that is with VMAT, and I will do the best proton planning. And what Shiva was trying to say in earlier case, if I can decrease my doses to the OARs, that is the pharyngeal wall, the parotids, etc., then definitely in this patient, proton will be a preferred choice, because we have decreased the morbidity of a patient who is going to be irradiated in a nodal and the mucosal area. So, and since the patient prefers, and if we have a space, why not? That is the question. So it will be a modeling based study that you do both of them, and then you can treat it. And there is also a small white paper at ASCO or from Astro that unknown primaries are also a candidate of a proton therapy. But they have lost the caveat whether it is level 2 or a level 3. So here it is level 1, right? So that is the caveat, you have to use it. I think if anybody wants to ask any other questions, I'm okay.
So there is one question, I think it goes to Dr. Shiva, Dr. Shivkumar for that.
Yeah, so I mean, the AJCC says 15, but then based on various studies, the adequacy of neck dissection in terms of nodal recurrence has been looked at, and as per that, the adequacy of neck dissection, especially in a selective neck dissection, should be at least 18 nodes, most of the time. See, it's not a hard and fast rule. If it is more than 18 nodes, it is kind of, the chances of nodal recurrence is lesser. It's not that it's never there. So anything less than that, I'm just worried that the quality of neck dissection or may not have been, as good as when it is done by a trained surgical oncologist. That's the only concern. So that would eventually reflect on the overall outcome for this patient. So that would be taken into consideration when you're planning for the treatment, but that is not the only thing to be taken into consideration. And that would not tell you that you have to give adjuvant radiotherapy alone for that. If you can just do a completion neck dissection and avoid an adjuvant, so be it. If it's in one node, less than 3 centimeters in size, only a single node, no nodes elsewhere, no extranodal extension, as per the various recommendations that are available, you could also keep the patients under observation, right? That's a very small group of patient. So in that situation, if there's only one node and the nodal yield is only 6 or 7, I'm worried that neck should not be observed. Either you go in and do a completion or you give adjuvant treatment for that. So if you want to restrict to a single modality, probably you will go in, do a completion, no nodes, observe the patient, reduce the toxicity, improve the quality of life. So it has to be an overall perspective. It's never singular.
So, Dr. Niti here. Sir, I think we're getting another question from Dr. Mastan Marsha. And he wants to know, hi sir, what are the volumes for mucosa irradiation in case of level 1 or level 2?
Okay, it's extremely simple. Depending upon the number of nodes, depending upon the number of station, your high risk will be 1 and the low risk. Okay, I don't know. Now anybody can hear? Shiva, you can hear me? Great.
Yes, you're audible, so please go ahead.
Okay, so basically the question is, if there is a level 2 node or if there is a level 1 node, what will be my volume of irradiation, right? So in a level 2, definitely you should treat it like when you are treating an oropharyngeal disease, if you want to treat along with mucosa. So the high risk, where you want to give 66 or 66 plus, if it is a curative situation, then you should be treating level 2 and the adjacent area as a high risk area, 2A, 2B, and sometimes 3 also as a high risk nodal station. So I am one of the proponent of whole neck irradiation. So level 1B, level 4, and level 5 will be my low risk. That will be around 54. Contralateral node, if there was a multiple node or extranodal nodal dissection, will be low risk. If you are a proponent that you want to treat only ipsilateral, then forget the contralateral node, okay? And don't treat any of those. Try to minimize those. And thereby you can decrease the radiation toxicity. In case of level 1B, I will be treating 1A, 1B, level 2A and B as a high risk. 3, 4, and level 5 is low risk, or you can omit level 5, ipsilateral. And definitely under the floor of mouth, part of the tongue, and ipsilateral alveoluses and gutter will be the part of high risk. So that will receive 66, okay, and the rest will receive 54 gray. So generally in 1B, as a choice, irrespective, traditionally how you treat an oral cavity, you should be treating like that. Lateralized oral cavity. In a level 2 and 3 or a level 5, how you treat a oropharynx or a nasopharynx or a hypopharynx, you should be treating like that. I hope I made it clear.
Yes. So there was one question, I think he messaged it to me in person. So please suggest if EBV negative and P16 negative is mucosal irradiation needed, is what one of them was.
So as Shiva has said it, and as per the likelihood of a P16 positive is low, extremely low in comparison to the West. Anywhere between, some people will report 10%, some will report 5%, some will report 21%, and max, if I recollect, it was 1/4. But still, it will help us to prognosticate and definitely make a plan for irradiation of mucosa. If you are not a proponent, of a mucosal irradiation. And if you still say P16 positive, you have to treat the oropharyngeal area. We can't get away with it. Okay. And similarly, it is for EBV. So EBV especially, there are multiple gutters at the fossa of Rosenmuller, even with your visualization, right? Unless until you are certain and you don't do a biopsy out of there, and if it is EBV positive, okay, you have to irradiate. So that gives us a confidence that no, this is the area which we need to radiate in case of positivity. In case of negativity, if you have a proponent that you are not going to irradiate mucosa, then fair enough. You need to keep them on a very, very close watch, especially if they are negative of all those places. But generally, what I practice is a mucosal irradiation, because in our practice, the likelihood that they will come for again and again follow-up and to do again imaging and visualization becomes sometimes difficult. So I said, okay, let me radiate with a modern technique of saving most of the constrictors to a dose of 54 or less, as well as parotid to less than 26 gray, at least on the contralateral side, and decrease the morbidity. That's my thought, always been there. That.
Discussed most of the aspects so far.
Sir, I think most of the aspects are covered. Just I think maybe some general suggestion on our guideline on how to approach a case from the radiation oncology perspective and from the surgical oncology perspective in nutshell. As a summary kind of a thing, if you can just give in 1 or 2 minutes, I think that should be done. Please, sir, as a take-home message.
Shall I go or
Yes.
you? Okay. Basic thing is good examination of a head neck mucosa. Second, don't rush for surgery. Do a nice biopsy. Speak to your pathologist, whether it is squamous C or adeno or what, right? Document what is the level of node. Talk to your radiologist about the disease, extranodal or no extranodal. Formulate a plan much before, discuss with patient. If you are planning irradiation, good dental prophylaxis, good swallowing exercises, all those will help. Good neck exercises if I am planning a neck dissection, okay? Because in my mind, unknown primary is a controlled primary. That's the devil's thought, Shiva. Okay, it's a controlled primary, or it may be a very uncontrolled primary, right? So that's the way people think of it. And definitely we should collate and data and do some pooled analysis or a randomized study from the Indian things, especially for HPV positive or HPV negative patients.
Right. So
Thank you, sir.
I would add to that saying that metastasis, cervical metastasis, unknown origin is a diagnosis of exclusion. So that should be done after all your workup, and that shouldn't be the first thing that should be coming up in your mind. As what has been discussed so far, we should have a proper plan of evaluation, clinical evaluation. Then not to, again, I would reiterate what Sir says, not to do an open biopsy, a true cut biopsy, image guided biopsy is better. Endoscopy of the upper digestive tract to identify any suspicious lesion. And the biopsy should be done after you have done an imaging, because otherwise that will add to the artifacts of the imaging. And it should be image-directed biopsy. You have done an imaging, suspicious site, you do an endoscopy, same suspicious site, biopsy that suspicious site. No random biopsies. Do P16, Iberish in the nodal true-cut biopsies. Now, role of mucosectomy, tonsillectomy, questionable, at least in the Indian context. We have no data, and it's not done in most of our institutes for various reasons. So it's not a must. And the treatment of surgery followed by neck adjuvant or chemoradiotherapy, SOS, salvage neck dissection, it depends. Both are equally good as of today. There's no head-on comparison. It may depend on your institution protocol and practices. So you can offer that to your patient, depending on the patient, and discussing with them what is their need. and what is that they're comfortable with, and because both give equal outcomes at the end of the day. And then the whether it's weekly, 3 weekly, I think Sir has already discussed. Proton therapy also Sir has discussed. So I think it's a diagnosis of exclusion, and the patients needs to be, worked up in a proper and systematic way. That's the thing that I have to say. Message. Thank you.
Thank you, sir. And I thank both the expert panelists, Dr. J.P. Agrawal and Dr. Shivkumar Tyagarajan, for their expert comments. It has been a fantastic webinar. I think to approach a case in a very systematic way, in a very planned approach, and by exclusion. That is, I think, most important message that you have given to our audience. And that has been, it has been a very good webinar, very, educational, and also which is practical. So I think it has been very much helpful to all of us. And even in we could not get the medical oncologist on board today due to some last minute medical emergency that he came up for one of his patients. So, but I think it did not really made a difference here, because you have covered all the aspects that were there for assessing a head and neck cancer unknown primary case. Thank you, sir. Thank you so much for sparing your valuable time and giving us all the guidance. And we take note of your suggestions, and we will try to work upon those things. Thank you, all the participants. And for participants, I have one request. Once you exit the webinar, you will have one survey coming up. Please respond to that survey. And if you have any questions, you can please mention there as well. Thank you.